This will be chapter 13, bleeding, shock, and soft tissue injuries. So we'll probably divide it into bleeding and shock, and then the second part, soft tissue injuries. We get into pathophysiology. That's where things go wrong. So we're going to talk about how these injuries kind of correlate with shock and respiratory compromise. Shock and resuscitation. We're going to recognize signs of shock, respiratory failure or respiratory arrest, and then cardiac arrest based on the assessment findings while you're looking at emergency medical response. This is part of trauma. So this is the first part of trauma. There's a couple of chapters in your book, chapters 13 and 14, that cover trauma. We want to learn how to recognize and manage bleeding, and then look at head, face, neck, and spine trauma. Anything with the head, neck, and chest, and somewhat the abdomen, can result in life-threatening emergencies. Anything having to do with airway, breathing, circulation, and this would comprise all of those. In the next session, we'll look at chest trauma, blunt versus penetrating. Anything that penetrates the skin would be penetrating injuries, and then all others would be blunt trauma. A little bit into abdominal and genitourinary trauma. We'll cover that primarily the latter part of chapter 14. And getting into soft tissue trauma, we're going to look at the different types of wounds, whether they be open or closed, and then get into types of burns, electrical, chemical, thermal, and then radiation burns, much like a sunburn. We'll talk about chemicals on the eye and the skin and how to dilute those, flush those with water. We'll also look at multi-system trauma. So this is where more than one part of the body has an injury. One part may be life-threatening, one part may be non-life-threatening, and a lot of those times those non-life-threatening injuries tend to be what we call distractors. That really grossly deformed leg, but the patient has also a closed head injury. A little bit on anaphylactic reactions. We kind of covered this in earlier sessions, but we talk about it when we relate it to shock. Diseases of the eyes, ears, nose, and throat, like a nosebleed. And it sounds real simple, but when we cover that in our soft tissue emergencies, you see that maybe some things that you thought you were doing right, you weren't. So an introduction. Any kind of damage to soft tissue soft tissues themselves or internal organs can cause life-threatening problems. Bleeding can be internal or can be external. External is pretty easy because you can see it. Most of the time we can control it. Internal bleeding is a lot different. You can't see it. Oftentimes you can't control it. All we can do is manage it. So any kind of excessive bleeding, whether it be internal or external, can result in shock. Shock is a state of collapse of the cardiopulmonary system. Shock is lack of oxygenation to the tissues, primarily the main tissues and organs that keep people alive. When we look at our patient assessment, we get into our scene size up. Remember all the safety things, looking at, how many patients do you have, and to be able to communicate that very early on. What's that mechanism of injury? Is it trauma, is it medical, or is it both? And then getting into the steps of primary assessment, the initial and the secondary including history, your rapid head-to-toe assessment of vital signs, and then that ongoing assessment that you do in your reassessment stage. And remember, those steps in the patient assessment, we kind of think of it as sequentially. The reason we teach it step by step is that you master it that way, and then with experience and maybe some more training, that you kind of develop something of your own. But the step by step keeps you from missing important things that you should be checking each time. When we look for signs and symptoms of shock, that's what you're going to find in your patient assessment. Oftentimes just looking at the patient and saying, wow, does their skin look really that pale? I remember pale skin is a lack of blood to those tissues. Cyanosis, the bluing of the skin, is a lack of oxygen to those same tissues. Looking at compensatory mechanisms like an increased pulse rate and then ultimately a drop in blood pressure for the classic signs of shock. We think about standard precautions. So you're responding to a call that sounds like it could be ugly, sounds like it could be multi-trauma. Make sure you have your gloves on ahead of time. If there's any chance of splash of blood or body fluids, then you want to also think about wearing a surgical mask and some kind of splash or eye protection that could help. Double gloving. Wearing 2 pairs of gloves. If you get the outside pair of gloves contaminated, you take those off. You've got a clean pair of gloves underneath without having to actually change gloves. Just a little review of the parts and function of the circulatory system. Remember, there's 3 main parts: the heart, the vessels, and the blood that flows through the vessels. If any of these become inadequate, then the result is shock. And I can't help but look at this picture and not notice the lungs. So we really think of it as 4 parts: the cardiopulmonary system. Again, if anything goes wrong, then the result is shock. For instance, the heart. The heart is the pump. If it fails, then that's the circulation, the blood in those vessels no longer gets pumped around. Oxygen no longer gets delivered to the tissues. The heart consists of 4 separate chambers. The 2 upper chambers are called the atria, and the 2 lower chambers are called the ventricles. Remember, the right side of the heart pumps blood that's lacking in oxygen, just came from the body, to the lungs and back to itself, whereas the left side of the heart pumps blood that's rich in oxygen to all parts of the body. The top 2 upper chambers contract together, and the bottom 2 lower chambers contract together. If you take your stethoscope and you listen, you hear that lub-dub, lub-dub. That's the closing of the valves that keeps the blood from going back flowing and keeps it going in one direction. Remember tracing a drop of blood. The blood comes into the heart from the superior and the inferior vena cava into that right atrium. It passes through 4 valves in the heart. The first one is is a tricuspid valve on the right side, has 3 flaps, goes into the right ventricle, then through the pulmonic valve, going into the pulmonary artery, goes to the lungs then, and then blood is taken into the lungs where it drops off carbon dioxide and picks up oxygen, returning to the left side of the heart into the left atrium. It passes then through the bicuspid valve on the between those chambers to the left ventricle, and then the aortic valve to the aorta and all parts of the body. If you look at this picture, you notice that the left wall, and think of the patient's left, not your left. It's going to be on the right side of the picture. But the left ventricle muscle is thicker than the right ventricle muscle. And this is because the right side of the heart only has to pump blood to the lungs and back to itself, whereas the left ventricle has to pump blood to all parts of the body. So think of it going down to the big toe and then returning back. It has to be a thicker wall to be able to do that. So it shows the contraction of the atria together and then the ventricles together. Blood that's lacking in oxygen coming into the heart, which is blue. Blood, and then it goes to the lungs, and so when it returns to the left side of the heart, it's rich in oxygen and it's red. All of the one-way valves keep the blood flowing in one direction. That's the pump, the heart, the pipes, the vessels. So arteries always take blood away from the heart. Veins always bring blood back to the heart. It's the capillary network in between where we're going to have semi-permeable membrane. What this means is that molecules of gas and nutrients and waste can pass through the capillary walls, very thin-walled vessels, where gas and nutrient exchange can take place. Arteries always take blood away from the heart. For the most part, arteries carry oxygen-rich blood, except for the pulmonary artery. And veins carry typically oxygen-poor blood, except for the pulmonary veins. I'm glad these are able to play now that you can see them. So it shows red blood cells going through the capillaries near the alveoli, and oxygen going into the alveolus so that the person can exhale and blow off the carbon dioxide, and oxygen going from the capillaries themselves into the structures, the tissues, the cells that need it. The fluid. So we've got the pump, the container, or the pipes, and then the fluid. And that fluid is blood. There's 4 parts of blood. The liquid part of blood, the fluid part of blood, is called plasma. Plasma is just the fluid part of blood. That's all it is. Red blood cells, which are the most numerous of all blood cells, carry oxygen and carbon dioxide. This is what gives blood its color. White blood cells fight infection. You think of the color of pus from an infected open wound, and pus is white. It's dead white blood cells. Platelets are also called thrombocytes, so they create a thrombus or a clot. Anytime that you have a cut or a laceration, you'll develop platelets that help stop that bleeding, even if you don't use direct pressure. And it just shows the flow of blood. Did you know it only takes 1 minute for 1 drop of blood to leave the heart and return back to the heart? 1 minute for all of your 5.7 liters of blood to circulate through your entire body. This circulation from the pump, the container, and the blood creates a pulse. A pulse is a pressure wave generated by the pumping action of the heart. And you'll feel this any place where an artery lies over a bone. So at the wrist, the radial pulse is felt at the base of the thumb. You can find your own. Sometimes if you press too hard, you make it disappear. If you press too lightly, you barely feel it. So it's kind of a gentle touch, and you find what works best for you as far as pressure. If the patient appears to be in shock, or if they're deeply unconscious, sometimes it's hard to find those, what we call peripheral pulses, and you want to go straight to the carotid pulse in the neck, like you learned in CPR class. Shock, then, is failure of the circulatory system, and it can be caused by a number of things. The heart stops working, or there's pipe failure. Okay, what does that mean if there's pipe failure? Not so much that there's a hole in it and we've lost blood, but think of it like this. The vessels or the container is supposed to hold the same number of liters of blood that you own. So let's say you own 5.7 liters of blood, but that container rapidly vasodilates. It rapidly gets large to where now it can hold 9 liters of blood. Well, you're going to feel half full, and that's will result in shock. Fluid loss. So if there's a break in those pipes and fluid is leaking out, predominantly blood, then it can result in shock. So pump failure, cardiogenic shock, occurs if the heart cannot pump enough blood to meet the oxygen needs of the body. So think of somebody in a heart attack where they're in heart failure, or somebody that has a chronic problem like congestive heart failure, where blood actually backs up into the vessels, particularly the lungs, where you hear rattling when you assess and auscultate the lungs, and you hear that rattling or a fluid bubbling sound. That's congestive heart failure or pulmonary edema. Pipe failure, again, is by rapid expansion of all the vessels, including the capillaries, and so blood pools in those capillaries and the rest of the body is deprived of blood and oxygen. The results then is blood pressure will fall and shock will result. Sometimes it's caused by something very simple like syncope or fainting. We call that a psychogenic shock. So have you ever had somebody jump out and scare you where, afterwards your heart was racing and your skin kind of got tingly? That's that sympathetic response to something that frightens you, and you have that fight-flight response. And the result is a rapid vasodilation of the pipes or the container, the vessels of the body. It's usually self-limiting if they actually lose so much blood from the brain, meaning that the vessels get so large that the blood actually pools in the lower extremities just due to gravity, especially if somebody's standing, and they lack oxygen and blood to their brain, then they actually faint. If that person faints, then they become horizontal, and the blood kind of balances out through the rest of the body. So it's kind of self-limiting. But other conditions like anaphylactic shock are not. That extreme allergic reaction to something that's foreign. It could be a peanut, it could be a bee sting, it could be any kind of allergen that the person has a response to. And that the patient will appear flushed, feel like their throat is closing up, so the breathing becomes difficult, and they have that rapid vasodilation causing the blood pressure to drop. And that prompt action that has to take place so that death doesn't occur is that EpiPen auto-injector. So if they have their own EpiPen auto-injector, they have a pretty good chance of surviving this. Spinal shock. So think of somebody, and I know, this can be kind of morbid, but somebody that hangs themselves, puts a noose around their neck and then actually drops and snaps that spinal cord. And what spinal shock is there's no more communication between the brain and the rest of the body. So the brain may be telling the heart to speed up and the lungs to speed up and the vessels to get tighter. And the body below the neck is like, man, we haven't heard from the brain in a while. Let's all slow down and relax. And the vessels get very large, and there's no what we call compensatory mechanisms. Nothing compensates to help the body out. The heart doesn't beat faster, the lungs don't breathe faster. And so from a spinal cord injury, those vessels can rapidly expand, blood starts to pool below the level of that injury, and all those vital organs are deprived of blood, resulting in shock. Fluid loss is the most common cause of shock. Fluid loss can be red stuff like blood. We call that hemorrhagic shock, or the patient is hemorrhaging. And it can also be clear stuff, just the loss of plasma without losing any blood. And there's a couple of instances that are pretty common. Somebody that overexerts and has excessive sweating, or somebody that has nausea, vomiting, and diarrhea, they're losing the clear stuff. They're losing fluid without losing blood. Burns also account for this. So somebody that has burns and they start third spacing, what that means is blood leaves the cells and the vessels and starts getting into their interstitial tissue. Wow, big word. It just means under the skin, directly under the skin, kind of in the fatty parts of the body, and they actually start swelling. So it's a fluid loss. And when that happens, the heart compensates by beating faster, and if the heart beats faster, the lungs will breathe faster to maintain that same amount of pressure in the pipes. Eventually, the body tires out, and then the heart rate slows down. We call that irreversible shock, and that results in cardiac arrest. External bleeding is pretty easy to see. It's pretty easy to detect. You do your rapid head-to-toe assessment, you can find it. Internal bleeding, not so much. So you can look for some subtle signs, though, like a bruise or swelling. And a bruise in its very early stages is just a reddening. It's not purple yet, it just looks red. It won't be purple for several hours or even the next day. Some swelling under the skin like a hematoma, or rigidity in that affected area. So the abdomen, when we did our rapid head-to-toe assessments on each other, we felt the abdomen, or you can feel your own, and it should be soft and non-tender. You can kind of push in, push around, but it doesn't hurt to do that. If it feels rigid like a board, the abdomen is a key area where somebody can bleed into, and you won't really notice it. Pain in that area can also be that. So whether that bleeding is internal or external, if it remains unchecked, unstopped, that person will continue to bleed and result in shock, pump failure, and ultimately death. So the average adult has about 5.7 liters, 5 to 6 liters, depending on your size, of blood circulating in the system. Any loss of more than 2 pints can lead to shock. So, you're really looking at about, 17% of fluid loss, total fluid loss can result in shock. Not a whole lot. Signs and symptoms. What are you looking for when we say somebody's in shock? Well, the organs that are going to be affected, the heart, lungs, brain, and kidneys. So as shock progresses, one of the first things that you'll see is what we call altered mental status. And that first stage of shock is a compensatory shock. It's compensated. The heart's beating faster, everything to keep the same amount of blood pressure. So maybe a little bit of confusion or restlessness. Restlessness is an early sign of altered mental status. Your patient's just fidgety. They're like, well, how long is this going to take? What are we doing? Why are we sitting here? What's going on? And they ask questions where you're just kind of like, yeah, they look like they're just a little anxious and restless. That's an early indication of shock, so be aware of that. The skin is normal, warm and dry. And now it's cool and clammy. So you have to think about, is it hot outside and maybe they're just sweaty? Well, then it should be warm and sweaty, right? If it's cool outside, they might be cool and dry, but not cool and clammy. So that cool, clammy, sweaty skin, especially if they're pale, We look for signs of compensated shock, like rapid breathing, rapid pulse rate, but weak. Increased capillary refill time. So we blanch the nail bed, we push down for 5 seconds, we let go, and it should return to color within 2. Anything greater than 2 seconds is a delayed or increased capillary refill time. Because whatever food and fluids is in the stomach, but the blood is being shunted away from those non-essential organs. It's going to focus on the brain, heart, lungs, and kidneys, not the stomach. So whatever's in there, they're going to feel, that patient will feel nauseated and maybe even vomit. They may feel weak. This is the patient that you want to put left lateral recumbent. If there's a potential neck injury, then supine, but really watch their airway. And then something that should scare you is if your patient asks for something to drink. Now, in a face-to-face class, I think this is more effective, but I ask students, what's the second to last thing Jesus said before he died? And a lot of people have to think for a second, what was it that he said? Mary, this is your son, this, the thief on the left, will be with me forever. The thief on the right will not. All the things that he said, but one of the things he said at the very end was, I thirst. Because this thirst is a mechanism. It's not that the mouth is dry, it's the whole body's dry. And all of the things that Jesus was saying to be recorded in history, he couldn't, that overwhelming sensation of thirst, he couldn't deny. And in the midst of it all, he said, I thirst. So when your patient tells you, I'm thirsty, and they show signs of shock, you need to be really worried. Don't give them anything to drink. All you're doing is giving them ammunition to throw back at you. But they're telling you, I'm in trouble. I'm in trouble here. When you see a drop in blood pressure, now they're in the stage of what we call decompensated shock. Because the body's going to do everything it can to maintain that normal blood pressure. When you have a drop, then we call that decompensated shock. So general treatment or shock. First thing, position. If somebody's standing, sit them down. If they're sitting down, lay them down. If the patient doesn't have a head injury, or if they're not in any big pain or difficulty breathing or whatever, lay them on their back or on their side, depending on if they don't have a neck injury. Now this picture shows them in what we call a shock position. Just want to let you know, we don't routinely use shock position anymore. You don't necessarily have to elevate the legs. Once you lay them horizontal, the body will pretty much manage the fluid shift itself. If they don't have any lower extremity injuries, no broken bones to the legs, and they're not having any trouble breathing, then you may elevate the legs, put them in that shock position, but it's not routinely done. Take care of their ABCs. Keep that airway open, give them high flow oxygen. You can see here they use a non-rebreather mask at 15 liters per minute. Make sure their circulation is good. Stop the bleed. If they have external bleeding, don't just go, it's something I got to take care of after a while. No, stop the bleed. Every drop of blood that they lose, they use oxygen carrying capabilities. Maintain the body temperature. So if it's summertime, you don't have to cover them up. But if they're telling you I'm cold, cover them up. Keep that body temperature, and those silver blankets are really good. Don't give the patient anything to eat or drink because it can cause vomiting. If they have something that they're going to go straight into surgery, surgeons want to make sure that they don't have anything in their stomachs. If you're trained in administration of oxygen and you're carrying it, make sure you provide high concentration of oxygen. Advanced level providers, advanced EMTs and paramedics will start IV fluids. And then rapid transport, that's the big thing. Whether it's by ground or by air, that's what's going to save their life. If there's pump failure, so this is a heart failure, not much that you can do. You can't stop the bleed. You can't position them anyway. A lot of people with pump failure end up with pulmonary edema, fluid in the lungs. So it's really hard to lay these people flat. These you want prompt transport to an appropriate medical facility, and that's going to be their best chance for survival. And when we say appropriate, we're looking for a heart hospital. Treatment for anaphylactic shock, again, transport as soon as possible, but if they carry their own EpiPen auto-injector and you're trained in helping them, you can assist them in taking this auto-injector. You place it against the outer thigh, kind of on the side, what we call the lateral portion. It goes through clothes, so you push it right through. and hold it, and they say for several seconds on the safe side. Let it pop and hold in place for about 10 seconds. As you pull it out, a lot of them have a safety cap, so you cannot be stuck by that same needle. It still needs to go in a sharps container. And then, be very alert for maybe having to give a second dose. A lot of them are carrying twin injectors now. They have double the dose, so they can be used twice. Otherwise, if it's a single dose, that's it. You can't reload it. You can't do anything else with it. Shock caused by internal blood loss. It could be from stomach ulcer, a ruptured blood vessel, or a tumor that causes internal bleeding and shock. And some signs and symptoms is some bleeding will come out of a hole of the body, like coughing or vomiting of blood from the mouth. If they're coughing blood, it tends to be bright red and sometimes bubbly, like if you put a straw in strawberry milk and you blew bubbles when you were a kid, or maybe you have a kid that does that, kind of frothy. Whereas vomiting of blood tends to be dark, like coffee ground emesis. The abdomen's tender, rigid, or bruising. They may have rectal bleeding, or in women, vaginal bleeding, and these can be signs of internal blood loss. So you can tell on these, it'd be real hard to stop the bleeding here, right? External bleeding is a little bit easier. On the very left picture in the hand, it shows a capillary bleed, so they've got a little puncture of the finger, and it's just kind of oozing out. We wouldn't be too alarmed. We'd want to make sure it's clean and dress and bandage it. Maybe check on their last tetanus shot. They should have a tetanus shot within the last 10 years. If it's a vein, like in the middle picture, it flows a little more copiously. Bleeding can still be controlled. Again, if they're bleeding a lot, I'm not going to worry so much about washing it, but stopping that bleeding. And of course, they'll need to either get sutures or staples or that glued back together. And don't think of super glue. It's a dermabond. It's made for human skin. Whereas in the very right picture, if they're spurting bright red blood, and every time their heart beats, they spurt that blood out, that's from an artery. Arterial blood's not impossible to stop. It's just not as easy to stop as the other two. So when we see these kind of bleedings, to identify what it is, whether it be capillary bleeding, we do direct pressure to the site. So take some gauze, place it over the wound, and put pressure on it. Venous bleeding, apply direct pressure for at least 5 minutes. And once it's on there, don't pull that gauze off. Don't go, let me see if it stopped bleeding. Every time you pull that off, you'll break those clots. Whereas arterial bleeding, that's spurting or surging, exert direct pressure, cover it with a dressing, and maintain pressure until EMS arrives, because a lot of times these will require something more intense than just direct pressure. So here's a picture of the gauze on there with a gloved hand, direct pressure. And it's dry, sterile dressing. I've had some nurses say, oh, you should have wetted this. You should have wet the gauze. It would come off so much easier. Now it's stuck to it. But the dry dressing with those fibers of the gauze is what promotes clotting. Wet dressing actually invites infection. So dry, sterile dressing, don't remove the dressing after you apply it. Sometimes we might have to elevate. We elevate the extremity that doesn't have a fracture in it above the level of the heart, and that's going to slow the blood flow enough so that can stop bleeding. Tourniquets. We used to say tourniquets are as a last resort. You have to apply direct pressure, you have to elevate, use pressure points, all this other stuff. And now there's a Stop the Bleed campaign. In most places that you see AEDs, a lot of people are placing combat tourniquets there. So if there's a shooting, it could be a school shooting, could be a number of different things, an explosion, that you can grab 3 or 4 of those tourniquets, and people that have severe arm and leg injuries, you can place a tourniquet on and stop that bleed. We always place it proximal to the injury site, so between the injury and the heart, never on a joint, and it needs to be with a wide constricting band. So this is in situations where that direct pressure does not stop the bleeding. Pressure points too can work. Usually where a wound is too close to the trunk to put a tourniquet on, like a shoulder or a upper thigh, that would be really hard to put a tourniquet on. So we can use a pressure point between the heart and that wound and occlude arterial blood flow so we can stop the blood flow enough so that the normal clotting process can stop the bleeding. So it kind of just shows brachial arteries and femoral arteries that you'll actually try to occlude with those pressure points. The brachial is kind of medial, so under the bicep. And then the femoral artery, if you raise up your leg, you've got a very large ligament there at the hip called the inguinal ligament. It's going to be just medial to that or towards the midline, and that is the femoral arteries. Make sure you have standard precautions with bleeding control. You're touching somebody else's blood and body fluids, so make sure you wear gloves. And if there's a chance of splash, that you're wearing some kind of face protection and a mask. But if you do get blood on your hands, make sure you wash it off as soon as possible, soap and water. 15-second rule, meaning you're washing your hands for as long as it takes to sing happy birthday to yourself. If you can't wash your hands, use a waterless hand cleaning solution, the waterless hand gel. And then whenever you can, after that, wash your hands with soap and water. I want to go ahead and stop here so we can come back and cover soft tissue injuries next.